Request Dr. Ansu Agagli to start her presentation. Wow. Okay. Sorry, Ansu. I think we'll complete mine. Then later on, they fix my problem. So, very good morning, all of you. And first of all, we should thank Namrata for giving us this opportunity, All India Ophthalmic Society. And also thank all the speakers from the APOS for readily coming forward and then presenting and then taking up this session. So this is, I don't have any financial interest except I'm the secretary for the society. And this is the overall scope of the presentation. So I would like to mention, see, everyone is talking about the AI and other things. Then for a simple understanding of what is AI, how it is going to be superior to the normal intelligence. See, natural intelligence, if you see, it's a learning process. So by different inputs, mainly all our senses will help us in educating and then getting the proper intelligence. So these are the aspects how we develop the intelligence. But that is a time-consuming process. The main challenge is there are several factors will influence the development of the natural intelligence, either by the nutrition or by the genetics or by the any sleep or the physical activity or environment, even the exposure. When you get a right exposure at right time, so that all makes all the difference. So with all these problems, how to overcome? So can we the process or build the artificial intelligence, or can the process be put into action? And if it is yes, then what you need? So basically what you need is basically a good sensors, like all our senses. You need a good sensors, the engineering sensors which can capture how our senses captures. So like the vision, then the sound, and then the perception. Similarly, if they have a developer sensors, so they capture the outside environment, and that will be transmitted to the central process that is called the chip. And then that is analyzed where we can develop a program then that will give you the desired output. This normally happens in our body, so we rarely recognize what is happening. Like if you see on on your left, see all the inputs, then it will be transmitted to the brain and then processed, and then the motor output will be delivered. So this is how, if you understand the natural intelligence and then the artificial intelligence, the sensor inputs they'll capture either by audio or video, and then transmission is by the nerves in our body, whereas by the semiconductors in the artificial intelligence or the mechanism. Then the software designers will develop a program where they'll capture all the input data, and then they will analyze, and then with the different algorithms, what we learned over a period of time, so they all now we publish. So now they are using that data for the simple programming, we're using by different algorithms, and then create an output which is far better than what we all do. So if you compare head to head, so human senses and the artificial sensors, then the transmission, our nerves will connect to semiconductors. They have matched that. Then all we acquired skills, they have put into deep learning. Then when all we master the skills, that they have defined into a machine learning. And then they program, and then the influence is the controlled artificial intelligence. So we are all affected by the different factors that all can be controlled very well in the artificial intelligence and the modern machines. The process can be performed in a predictable, efficient manner in a very short time consistently. So that is the advantage of the artificial intelligence. That's why everyone talks about the semiconductor industry, microchip, all these things. These are all nothing but the back end of the what we talk about, the artificial intelligence. Behind the artificial intelligence, this is the process. See, gathering the data, then the once they create the hardware, then they gather the data, and then the data preparation, then the data wrangling, and then the analysis, then the train model, and then they test those models, and then basically again they are testing on human beings. So we commit or we refine them. They're saying that this is wrong. So machine learns from that, and then they refines, and their next versions will be far, far superior than us. So the more you handle the AI, the more the AI is getting intelligence rather than we are getting more intelligent. So that is the entire process. See, coming to the applications in the cataract workflow, see this basic, I think, if you now want to apply on the cataract, right from the outpatient, from the diagnosis and then the decision making, counseling, biometry, image guided surgery, phacoemulsification, and post-op outcome analysis. At every step, we can incorporate the AI-based models. So this is in the pre-op evaluation. Now we have the wavefront analyzers where we can, sometimes we'll get a doubt whether the visual loss is corresponding with the media changes and with the normal macula. Or sometimes patients complaining of severe blurring, but if you see there will be 6 and hardly any cataract. Now we have the equipment where we can analyze, that is called the dysfunctional lens syndrome. It scores from 0 to 10. The lower the score, the more the disturbance. So with this, the gadgets, we can confidently advise the surgery. Then next comes the counseling. So we can, they have developed an excellent models where we can give the checklist to the patient. So they can, like all those symptoms, expectations, they can feed into that program. So finally it will tell both surgeon as well as for the cataract patients what IOL they will choose. From surgeon side, what is the precaution we should take, what is the realistic expectation we can get. All these things can be utilized in the AI model. Anyhow, we all know it is very well time tested, the Hill RBF AI integrated model. The results are far, far superior than the SRK and SRKT, Barrett's and all those things. Then next comes the incision image guided surgery. So there are excellent tools, digital imaging, where it captures the images in the pre-op. Then you can see on the left side with the arrow that continuously gauges the movement of the eye, and then it will even guide us how far we can go for the capsular axis, whether we are in the right size or not. So that also helps in the IOL axis placement and then IOL centration and other aspects. This is in the image guided aspects. Then comes the chamber stability. And when it comes to the surgical aspects, now their Centurion machine has got the active centrifluidics, where the sensors are placed right in the phaco probe. So very near to the chamber, in fact into the chamber. So even the shortest time, they'll capture the fluctuation in the chamber, and then the mitigation will be done immediately, the corrective measure. See, if you can see here, 8 times the probe has detected and then corrected itself and prevented it being happening. So this is the kind of sensors which they have developed. With that input, with the software design, they can go to a mitigation prevention. Now what I was suggesting them is, let us incorporate the same thing in the phaco delivery system. When we are using an energy or the power, so with the foot pedal, so the kind of resistance it gets, the machine should capture, and the average amount of the energy which you are using, So machine should calibrate and then tell us a warning that this is the because it is very difficult to predict the hardness of the lens or the stickiness of the lens unless you directly phaco it. So very only 70-80% of the time only we can predict the hardness before surgery. Actual fact will be known during the surgery. So this, if the machines can capture that feedback by highlighting this phaco delivery, so then it can change automatically to the next mode, and then it performs the surgery. So this is what I was suggesting them. They promised me that they'll incorporate this in their new model. Similarly, in the visco evacuation, at the end of the surgery, the biggest challenge is how completely you can remove the viscoelastic. So viscoelastic causes the postoperative raise in IOP, and in spite of doing a good surgery, now especially nowadays most of them are the daycare surgeries. So in the middle of the night you will get a call saying the severe pain. So then what I try to do is I'll use the vacuum settings at the end of the nucleus removal. So at that stage the anterior chamber will be filled with the BSS. So that is the basic vacuum, which the resting vacuum for that eye. So at the end of the surgery, after inserting the lens, then I'll again put right now if you put the IA probe, then it may not match the output. Then I'll use the same, I'll pause here. Yeah, I'll use again the phaco probe and see that the vacuum setting which I got at the end of the nucleus removal should match the vacuum setting at the end of the viscoas. Till I continue the aspiration till I get the post nucleus removal vacuum setting. So that assures me that the anterior chamber is now the vacuums or the status, the resting vacuum will be similar to that of the eye filled with the BSS. So that indirectly assures me that the viscoelastic is completely removed. Now they are developing this model into their new Ingenuity viewing system, where it can even capture the viscoelastic viscosity movement as the shadow. So then they are incorporating that into their new model. To summarize it, see, natural intelligence, it's a time consuming. That means one has to grow 20-30 years to develop the intelligence, complete wisdom. And it's variable from individual to individual. And then the artificial intelligence is hardware and software is ready now. It can overcome the natural intelligence shortcomings, and it can be applied to the medical field especially, and then from diagnostic to procedures. That will improve the safety and outcomes, and it can improve the standardization of the care. So take home is artificial intelligence is ready, and it's a reality, and it can be applied to the cataract surgery patients at all levels, and it will definitely improve the safety and outcomes and standardizes the care. Thank you very much.
Sir, I have one question for you.
Yeah, right.
Excellent talk. It was really nice to hear those things from you. So with all this AI taking up and things, so where do the cataract surgeons stand? So you'll always need a cataract surgeon to use these things, or they will come where the robotics will take over?
So recently when I was, I met one of the surgeons group while I'm traveling back. They're all coming back from a conference of the robotics surgeries. What I heard from them is now they have gone far ahead of the robotic surgery, And the main the hindrance or the block is the cost of the instrument, robotic instrument. And only that Da Vinci or one company is making it, which is only US, and it cost almost in 10 to 12 or more than 12 to 13 crores. Now with Make in India movement, and then once the patency is over, now 2-3 companies from the India, so they developed a robotic model. And they were, it seems the main machines and then the other things are in Bangalore. And then that can be accessed online to even to Rajam and Srikakulam and in the remote places. And they were all cholecystectomy, everything. So they will buy an Indian version, and that can be, actual robotic surgeon can be there in Bangalore and other things. So it makes very easy for them. So similarly, all these, once if you develop an AI model and then the machine learning model and then the robotic options, then things will change. But coming back to your question, and I always tell the people that AI will never replace the human beings. AI, what I see is, it will help us to deliver our result in a faster and much superior, like 10 times, 20 times, 30 times the better than what I do. So coming back to your question, still I will be a cataract surgeon and cataract surgeons will be there, but what I am producing the result. So with the AI, the future generation can produce 20 to 30 times better than what I am producing now. So I think I answered your question.
Yes, sir. Thank you.
So, and at the same time, the reality you should know is patient expectations will improve by 30 times. Like how the retina surgery has shown us the expectation. So we will always be trying to catch up the patient expectations in future. Still, our condition will be the same. Only thing, the way we do will be better than what we are doing now. So that's the only thing. The best example is your retinal surgery.
Yes, sir. I agree.
Because I am the person who has seen assisting the dissection, putting the implant, and then SRF drainage, dry tap, bleeding, next day not attaching. But now if you see, sometimes the retina surgeons are finishing faster than my cataract surgeries.
Yes, sir, it does happen.
Thank you.
Thank you, sir.
Now I request Ansu to start her lecture. So next session, please excuse us. Actually, they have given 45 minutes late to us, so we'll hand over.